important. Okay?
Yes.
So your clarity concepts is not good. Your slide is not matching to the content. So that means you are not acceptable. That means you are not done a work. You are coming from DRB and just presenting. So still your mind is in DRB. You are not come to the medical college. Yes, next point.
This is the video, sir.
What is the nature of the injury?
Incised wound, sir. Axe fell on his leg, sir. Direct cut injuries.
Somebody accident or just
No, accidentally, sir. This we have done tendo Achilles repair with Krakow technique, sir. This is the post-op X-ray.
This is after suturing.
Yes, sir. After suturing. 55-year-old female with 6-year post-op status, distal third shaft fracture. Picture.
Taken a close-up picture. Okay. What is the post-operative protocol?
We have applied ebony slab, sir, with foot in plantar flexion and a knee in flexion, 30 degrees of flexion, sir. Until
going to break.
cast, sir.
Yes.
Cast we have applied, sir.
Cut a window.
Yes, sir. For dressing, sir. For 4 weeks, above knee, sir. Then we convert into below knee, sir. And after that, we change the cast into in normal position. We will keep after 3 months, sir. Foot in normal position.
3 months.
6 weeks, sir.
Neutral position, not
Neutral position, sir.
See, your protocol is not good. See, there is Campbell's protocols and also Rotterdam protocols. This is the after treatment protocol. If tender case is very, very important. 6 weeks above the knee, 3 weeks below the knee with the window. For 3 weeks and direct girl, or 3 weeks low, you have to foot and so what you call heel and sole uniformly elevation level. So you keep on reducing down. So in the first 6 weeks, this
Foot in plantar
there
flexion.
may be a difference of 2 centimeters of 1 inch between the heel to the ground. So that should be slowly come down. So every week you have to cut down till you get a
Plantigrade.
That is from 6 weeks above with the window. And then restore the
Dorsiflexion.
Serial. In a serial
Serial.
way. So you have to correct
Sir?
the heel and sole.
When it is a partial tear, sir, or percutaneous fixation is done.
If you see
Early.
in 1-2 days, then as well go for.
Conservative manner.
But what is the difference between conservative and operative in the long-term results, in terms of long-term outcomes?
Early mobilization.
Go for conservative. What is go for conservative? Advantages of conservative.
No incision. There is no incision. Common neurovascular
Scar rupture.
scar ruptures.
Scar basins, scar
Yeah.
healing problem. Will be there.
Yes.
You get a vascular region.
Yes.
What is go for repair?
Under observation, we can suture, re-rupture.
Re-rupture of the tendon is less
Less.
compared to conservative.
55-year-old.
Cause for re-rupture. So what is that tender case? It's
Fine.
got type 2 collagen.
Collagen.
Once you suture and everything on the heal process, the type 2 will go to type 3 collagen. Which is the strong collagen? Type 2 or type 3?
Type 3, sir.
Huh?
2, sir.
Type 2 is a strong collagen. Type 3 is a weak collagen. It is not a original. Replaced by the replaced. That would then power the clone. So there is high chance of re-rupture.
Re-rupture. 55-year-old female with 6-year post-op status, distal third shaft fracture of right tibia with implant in situ. We have done implant removal, sir. 79-year-old female with intertrochanteric fracture of left femur. It is Boyd and Griffin type 2. We have done CRIF with long PFN for left femur.
Results are better with long PFN or short PFN?
Long PFN.
Why results are better? Why results are better with long?
Stable fixation.
Why results are better with long PFN, not with short PFN?
Stable fixation.
Working length.
Working length.
Working length is more with the long short PFN. Because earlier we have
Early
stress riser effects are less. But we have to assess the fracture configuration and the quality of the bone. Quality is different, quantity is different. Which is more important? Quality, quantity.
quality.
Quality. That's correct.
44-year-old female with fracture dislocation of right shoulder, sir, with no distal neurovascular deficit. It is 4-part fracture, sir. We have done open reduction internal fixation with Phillows plating for right humerus, sir. The C-arm fix.
Is there varus collapse, no collapse?
No, sir.
Show the calculus too. Show the calculus. Where is your pointer now?
Yes.
You have no pointers. You have calculus.
This one.
Is there no collapse? Collapse or collapse?
No, sir.
There was a application by one surgeon from Hyderabad to prevent varus collapse and to give additional stability. Whether he has inadvertently done in the first few cases or not, we do not know. He has shown that medial displacement of the distal fragment will cause it more stable and prevents varus collapse, and union rate is very good compared to the conventional anatomic reduction. So he has created a gap between the plate and the distal fragment and then made the fragment to get displaced medially. Purposefully, he has shown better results and preventing the varus collapse. Like,
Displacing the middle.
displacement, it becomes more stable.
Stability, okay, but varus still maintained. That's what I meant to say. Fracture can unite, but the varus is still maintained there. Now, if you are displacing this here,
Collapse is prevented.
that's what. Otherwise, varus is still maintained. Doesn't matter. But this what you want to say. If displace this side, as we took McMurray's, definitely works in McMurray's. It unites definitely. But one also లేదు కదా. But all these things. But this middle displacement with fixation is enough. But it will not serve any purpose, I think, right? But what was the approach they have taken for this? You have
Deltopectoral. Deltopectoral
you were
approach.
there for the surgery.
Yes.
Hmm?
Yes.
You are there.
Yes.
No, senior or junior? I put him.
Senior.
Senior, you should know. All right, tell me now, what approach you have gone? Is it easy to reduce or difficult to reduce?
Sir.
Was it easy to reduce the dislocation?
Yes, sir.
Was there
Closed reduction not right, sir. Not right.
even it?
Should not, sir.
Can you get?
Because it is 4-part fracture.
But even if you openly reduce, is it that easy to reduce it or do
No.
something else? You are there or not? Just tell me what problems.
I did not. I
then-
did not assist, sir. I came late a little.
Then what you
I
see-
was there.
But is there a problem even if you open everything? The dislocation very difficult sometimes. We'll have to all around release everything and put it back. But that's the reason we get avian easily. If you dissect. Yeah. Unless, yes, that's what.
Cut it and then reduce it. That is a very commonly encountered problem.
GT was fractured or no fractured?
Fractured, sir. It was. Super.
Yeah.
Yes, sir. Abdomen. Impingement. Supraspinal testing. Here 60.
Failure, huh?
Having a good purchase over the stove, probably a tension band is going to give additional stability because the abductors keep on
Abductors.
especially
Great
the
adversity.
rotator cuff keeps on pulling the left perspective. So that's an additional stabilization that is required to enforce partial axis.
But all said and done, whatever you do, Phyllis fluid is not that much encouraging nowadays. People have been spoiling it, many complications occurring it. I don't know what. Some people use other ender snails, other things they use. Or just putting a, close wire, that's enough. But putting this much of dissection, they have a lot of problem.
KY put them for 4 to 6 weeks, pull out them,
And leave it.
mobilize. Irrespective of what you are going to do, ultimately the end result, the range of
Even
movement
decreased.
is reasonably comparable with any method of displacement. Because with this we do lot of dissection.
Then this is not perfect also. There is always breakage and then loosening of this. There are a lot of problems with this.
Especially elderly people with
Yeah.
osteoporosis.
Young people, right. Yeah. Best. Only young people who are there, they can have all this. Otherwise, no point doing it.
This is a 63-year-old male with 1 year post-op status, grade 3B wound, grade 3B middle third shaft fracture of right tibia with implant in situ, sir. First he got external fixator done outside, sir. Then it was removed after 6 months and ILN was placed and it got infected, sir. They came with open wound discharging sinuses, sir.
The first one is straight up.
First one was external fixator, sir.
Can you have the images of first one?
No, they don't have,
The
sir.
X6 was kept for 6 months.
The wound did not heal, it seems.
That is not the solution. That means some problem is there why the wound is not healing. The purpose of X6.
The purpose of X-fix is only to manage the wound.
Manage the wound.
You have to expect that the wound heals in 6 weeks. If it is a with skin loss exposing the bone, you have to do a flap. Otherwise, the exposed bone becomes sequestrated.
Yes, sequester.
That is why the wound never
Infected,
heals.
sir. Yes,
Okay,
yes.
a maximum 6 to 8 weeks X-fix. Ideal is 6 weeks. That is the time to given for if any flap transfer is done, the flap gets matured in 6 weeks. It gets
Yes, 1 year old.
so with nail in situ.
Nail in situ, sir.
Yeah.
Infected nail, sir. We have removed nail and now we got Enterobacter species, sir. Culture report came just.
But they will culture it and give the appropriate antibiotic. What here the organism is not going to. It is important. They will do culture and give the appropriate antibiotic. Here the management is regarding the wound. Infection anyhow will be treated. Yes.
We have done implant removal, sir. Irrigation, wound debridement and irrigation was done, sir. And dead sequestra bone removed, sir. And fibulectomy done. And
Fracture was exposed and
fracture-
debrided.
Yes, sir. Fracture
Any
was
sequestrated pieces are there?
Pieces removed, sir. Sequestrum
Is
removed,
there
sir.
any shortening after
Yes, sir. Shortening is
Okay.
there. And fibula, we have cut, fibulectomy was done, sir, for docking purpose. And we applied Elizaro fixators. And this is the status of wound, yes, sir. We could not approximate this wound, just we applied stay sutures. Yes, sir. No, not, no corticotomy, sir. Fibulectomy only done, sir. Fibulectomy done, sir. Fibulectomy.
that? No corticotomy.
No, we,
How do you dump the fracture? Later date.
sir,
How do you want to get compression into fracture site? There's a gap, no?
yes.
So how do you oppose both the fracture fragments? How do you get good compression, solid compression? Solid union.
The question should
With
be: are you going to achieve acute docking or docking by transportation?
Transportation.
That is
Docking by transportation.
okay.
Sir?
Only fibulectomy.
Yes. No. Distraction. Yes.
But the frame is Elizarov frame.
Elizarov.
Okay.
Yes.
So what is the purpose of this frame?
For correction of deformities.
There is no
in
deformity.
non-union-
Fracture can
in
be aligned.
non-union cases, sir. Treatment
Ah,
of
yeah.
non-union cases.
How is it going to help with the infection? How is it going to help to control the infection? Here you can do acute docking.
Acute doc.
Okay. Of course you can. Yeah. Yes. How is the infection going to bring under control? The best advantage with this is the patient can be mobilized immediately
Yes.
after the frame.
After the frame.
Right from day one, weight bearing can be started, wherein the biology will improve in the leg rather than non-weight bearing. So improved biology, vascularity of the
Increase.
fragments is going to
Increase.
enhance the chances of union.
Yeah.
And what is accordion? Accordion effect in Elizarov.
Musical instrument.
Huh?
Musical instrument.
It's a musical instrument like harmonium.
Yes.
So it opens
Distraction
up and closes. Why is it
compression.
called accordion effect in Elizarov?
Because we can do distraction as well as compression both.
Yeah. So the infection dies out in the fire of regeneration. That is the term coined by the great Elizarov. So even in presence of infection, if you generate intense inflammation by distracting, all the fibrous tissue will be disturbed and it bleeds. Bleeding will produce cellular response. Thus cellular response is going to help in the regeneration and control of infection. So the phagocytosis will improve. Okay.
Open, sir.
She has already told that debridement was done. Sequestra removed.
removed, sir.
Yeah. It did not went well now. It has to end.
Compressions. By tightening the bolts 1 mm per day.
Yes,
compression.
right. Okay. Next. Second year. మొన్నే డిస్ట్రిక్ట్ పోస్టింగ్కి వెళ్ళి వచ్చారు ఫస్ట్న 3 నెలల నుంచి కనపట్టలేదు కదా కాదు వీళ్ళందరూ అక్కడి నుంచి వచ్చారు హేమనందన కూడా.
Good morning, sir. These are the cases done in Unit 2. 55 years male with closed tibial fracture, fracture of right tibia and fracture of base of 5th metacarpal and hand of 4th metacarpal of right hand. It's a Chartres type 5, sir. It's a bicondylar fracture. These are CT films.
Displaced or undisplaced?
It's undisplaced.
Okay. What is your plan?
We have done.
Articular congruity is well maintained.
Yes, sir.
Both in CT as well as see the CT. So coronal unsa ya babu. See in the coronal plane.
Sir.
Very good congruity.
Yes,
No
sir.
depression. Even in the sagittal plane, no depression.
No depression, sir.
Congruity is excellent. But a little impaction at the metaphyseal level.
Yes. We-
55.
55, sir.
Elderly?
Yes, sir.
55 is elderly.
Right now it's elderly.
Huh?
Only, sir. Yes, sir. Is only working. Yes, sir. But we can prevent knee stiffness and, if we do surgery. We can't guarantee,
With
but
the
we can
double
start
plating,
early mobilization.
Huh? Can you achieve normal knee range of movements?
No, not
No.
normal, but
You should. That is the purpose of fixation. Early mobilization. Okay?
okay.
Don't put a slab for 3 weeks, 6 weeks. Okay. You will only get satisfied with the X-rays, not with the function.
We have done ORIF with dual plating for right tibia and K-wire fixation for 4th and 5th metacarpal. No, sir.
అదేంటి ఎస్ షేప్డ్ కే వైర్ ఉంది?
Fifth one is antigrade.
Base as well as neck. Yeah, tilt rotated. ఇక్కడ 4th. 5th బేసా నెక్? రెండు నెక్ ఏనా?
No. Bennett's only it's a part.
అది నెక్, ఇది బేస్. ఫిఫ్త్ ఇస్ బేస్ యాంగులేటెడ్.
Fifth base, 4th head, sir.
దట్ ఈస్ నెక్ రొటేటెడ్.
Rotation. It's a head split.
You have to mobilize very early, dual plating.
Yes, sir. We started knee bending.
Okay.
20 years female with closed middle third shaft fracture of right femur, sir. So we have done ILN for right femur. 40 years old female with closed distal femur fracture with interarticular extension of right knee, sir. So CT flims. Sayomula type C, sir. We have done ORIF with plating for right femur, sir. We have gone medial approach and lateral. It was very comminuted, sir. So we have tried there. As much. Yes, sir. Sir? Here there was no fragment, sir. It was rotated, so we have brought and we have fixed it. Yes, sir. C3, sir. C2 with is a component of OFA also, sir. Yes. Metaphyseal combination also. Articular. C3. OFA chinna fragment completely. Medial only, sir. Hubbard screw, sir. Article. So, so no, sir. So entry will be from it's a notch. We can sir.
Right side line is there.
there's a
especially with metaphyseal continuation. Otherwise, while opening, you are devascularizing the tract.
no articular. There's a break in articular so step on the asana and rotation of fragment also there.
Especially the OPA irregularity, incongruity can cause that compartment arthritis. There is no OPA component. Or
33-year-old female with closed middle third, distal third junction fracture of the right femur, sir. We had an ORI with plating for the right femur. So partially articular involvement. Yes, sir. So we have done plating, sir.
Helicopter. Yes. So unicorticals. We have put unicorticals to all this. Unicortical.
but since there is no articular continuation, probably interlocking nail with adequate purchase in the condylar fragments also is advisable. This is anyway a stress driver. These people should be advised implant removal after 1.5 to 2 years. Otherwise, they are likely to develop a
Subsequent fracture.
Is it biological?
Yes.
Yes, sir.
Yes.
So it's no. Submuscular.
Yes.
Some movement.
PT.
Is there any role of RO in knee brace? RO in knee brace?
Yes, sir.
Which is cumbersome? Plaster is cumbersome, RO in knee brace? Which is cumbersome?
Plaster.
Plaster is cumbersome. So our motto is give comfort to the patient. Never create problem. We want solution.
60-year-old male with 9-month-old fracture neck of left femur, sir. We have done bipolar cemented hemiarthroplasty for left femur. Subcapital. Sir, when we were putting the implant, there was GT fracture has occurred, sir. Vertical split. That's the reason.
Split.
Vertical split has occurred. No, sir. Just
implant పెట్టంగానే వెళ్ళిపోయాను సార్.
yes. No, sir. Delayed wait.
6 weeks.
4 weeks.
4 to 6 weeks.
21-year-old male with closed middle third fracture of left clavicles. Had an ORF with plating for left clavicle. Yes, segmental. Had an ORF with plating, sir. No.
We contoured or we have contoured?
No, sir, it's already clavicle contoured plates, sir. Yes.
Now we have got all Indian innovation plates also. It's not necessary always to say things or you. India all the
Good morning, sir. So, 45-year-old female with closed comminuted transverse fracture of the right patella. We've done transverse with comminution, sir. The inferior pole of the. Yes, sir. Direct injuries. Morning, sir.
transverse fracture which is widely opened up cannot be a direct fracture. It's an avulsion fracture.
Yes, sir.
It's an indirect way.
No injuries.
No injury.
No injuries, sir.
Nature of injury you do not know.
Sir.
Yes or no? What is the mechanism? How patellar fracture of this nature will happen? What exactly happens?
The flexion, excess flexion of the knee joint.
Excess flexion will cause fracture?
No, sir. On impact and.
So falling on a flexed knee, and what happens when you're falling on a flexed knee? What happens to the quadriceps?
The quadriceps will pull the superior pole and.
So it is sudden contraction of the
Yes.
quadriceps against a flexed knee,
Yes.
like elbow, like here. So it is indirect.
Yes.
So falling on the feet.
Yes. We've done open reduction internal fixation with tension band wiring and 2 4 mm cannulated cancelers. So there was we had to achieve reduction for the comminuted fragments. So we had to put.
How big was the comminuted? Go back.
I'll zoom in.
All right. Basic thing is tension band wiring. How do you
Yes.
know how tension band wiring works?
Yes, sir. It converts destructive forces to compressive forces. So in it converts the pull of the quadriceps on the superior pole and pull of the patellar tendon on the inferior pole into compressive forces.
Compression where? Anteriorly, posteriorly.
All throughout. Screws are anterior.
So compression happens at the articular surface, posterior.
Yes.
So your KY should be anterior to the forceps.
Force. Yes, sir. Yes, sir.
Okay, go on.
75 years female with intertrochanter fracture of right femur, sir. Byard and Griffith type 2, sir. We have done close reduction internal fixation with short PFN, sir.
Which unit is this?
First unit, sir. 75 years female with intertrochanter fracture of right femur, sir. Same Byard and Griffith type 2, sir. We have done short PFN, sir.
Still opening is there, it should close that.
Yes, sir.
21-year-old male with closed tibial plateau fracture of the right leg. This is a Schatzker type 5, sir. There's a bicondylar fracture. So we've done open reduction internal fixation with the posteromedial plating for the medial plateau and cannulated canceller screw fixation for the lateral plateau. Used the screws as a raft. Yes, sir.
Yes, sir.
Yes, sir.
There is no comminution.
Sir,
There is no depression of the that principle applies when there is a articular convolution with the depression.
yes.
When you put the screw subchondrally, it acts as a very good support. So that will not allow it to suffer.
Yes.
Here there is no depression at all.
Yes.
So this is not a true raft principle, but
Yes.
it is a method of stabilization.
Yes.
Relax to that.
Yes.
21 years male with closed middle third shaft fracture of both tibia and fibula of leg flexor. We have done ILN for left tibia, sir.
We need your name. We need
Sir. Yes. And this place.
There's a butterfly fragment.
Huh?
So there's a
Butterfly
butterfly fragment from a spiral fracture. So he's a young patient.
Environment for better union.
Yes.
The butterfly is there, wider fracture surface, provided it is not displaced. And
I
wider
think this is taking to the extreme. Probably could have treated with a plaster initially. After 2 weeks, good PTB.
Yes.
even initially also if there is not much of swelling, you can put Cernian to plaster right from day one. And you have created gap at all.
What are those things? What did you do? Those are artifacts.
Through holes.
Steam and pins, sir.
Oh, Stephen, what did you do? Those statement, why?
To achieve reduction, sir.
There was nothing to reduce, already reduced.
While reaming, sir.
Yeah. Excel is good. Okay.
So 30-year-old male with closed middle third shaft fracture of the left femur with closed proximal tibia fracture and both bone fracture of the left forearm. We've done closed reduction internal fixation with long PFN for the left femur. ORIF with plating for both the radius and ulna, and ORIF with medial plating for the tibia. This is a 26-year-old male with grade 3B compound proximal phalanx fractures of the third and fifth toes with gangrenous changes in the third toe. So no, sir, he's not a diabetic. Young patient, 26-year-old.
Why gangrenous?
Sir, he presented late. He presented after almost 1 day of the injury.
Okay.
Crush injuries.
Basically, question.
Bike versus bike.
Don't call gangrenous then. Necrosis.
Necrosis.
What is the difference between gangrene and necrosis?
Gangrene is a chronic change. Sir.
Yeah, keep driving. Gangrene is generally reserved for vascular.
Yes, sir.
Vascular venous or arterial block is there, then gangrene. Crush injury with the tissue necrosis.
Yes.
The thicker appears to be viable. Before the toe appears to be viable.
Sir, we tested it. The sensations also were lost, and the capillary filling in the nail bed was absent.
Now, did you try to prick and see bleeding?
Yes, sir, we did.
Is it bleeding?
Small. It wasn't.
Wait and watch.
Yes, sir.
Because the crush injury.
Yes, sir. We've done disarticulation of the third toe and closed reduction internal fixation with K-wire fixation for the fifth phalanx fracture.
What will be the future of that foot? We have done disarticulation. There is a gap between the second and the third toes. What will be the fate? What is the future? Because it's a opening to the
Second.
do not know whether it is going to be primarily or not. What will be the future of it to give a better appearance? In this way you have to do ray excision with a lateral there so that the gap is closed and the foot looks near now, functionally as well as functionally. do it, it is likely to get infected. Further worsen.
33 years male with 9 months old intercapsular fracture of left femur, sir. Transcervical traction.
How do you know from?
9 months old, you cannot classify typically.
Okay, sir.
So what do you call this? What do you say?
Trans.
Do you say it's a fracture, intercapsular fracture,
Yes, sir.
or something else?
Yes, sir. Intercapsular. Fracture at neck of it.
What is the complication happening?
Resorption.
What is the
Resorption.
diagnosis now?
Resorption of the neck.
What do you call the diagnosis here? What
Fracture neck
what
of
complication happened?
avian.
How do you know avascular necrosis? You miss main thing and talk about all other things.
Non-unit, sir.
Non-union of fracture neck of femur.
Yes, sir.
That's the diagnosis. And how do you know avian or not avian? Can you make out from the X-ray?
There is no avascular.
What is there on the X-ray? Can you see? What is the difference between this head, normal head, and
It's
affected
the
head?
yes,
Not
not there, sir.
So when do you say avian change? What are the avian changes? That's what I'm asking.
Sphericity of
Sphericity is
of
not
not
sorry, what else? Before sphericity, what happens?
cysts and sclerosis. Cysts and
Sclerosis.
There will be sclerotic
Sclerotic
areas.
areas.
And is it sclerotic or other way around?
Verified.
It's
Transfer.
there is osteoporosis
Porosis.
and no cyst. Spherical, look like a shell. You don't know whether it's avascular. 9 months, would you expect avascular necrosis?
Yes, sir.
But it might
Yes,
take
sir.
longer. Might be.
How about joint?
Hip joint is normal or arthritic?
It's normal, sir. Okay.
This is
not
your exam case. This is the case you're going to face. You're going to treat. To become a good orthopedic surgeon, you should be able to manage this.
As Tuesday only case was present.
This is
Other
examination
case,
case.
it was present. Illegal Ajay sir.
Avian.
Don't operate. We'll operate in October. Admitted, huh?
First half, sir.
Bipolar.
Go back.
Osteosynthesis or replacement. First question.
Engage osteosynthesis.
The CC screw
Cis.
fixation can be done.
We should have saved. Trial of.
You see, there is another X-ray, long X-ray. There is a fairly good calcar,
There is neck as
and the
well.
density appears to be better than this is a X-ray artifact showing so much of porosis. But this X-ray appears to be
Neck also little intact there.
yeah, intact. Fairly good calcar is there, rounded off, but
Could have tried the tubular graft. Osteosynthesis.
or muscle pedicle graft.
Poor patient.
Yes, sir. Poor patient.
Go back. How long is going to last? What is the occupation?
Farmers.
Farmers.
Farmer. How long is going to last?
15 to 20 years.
Done well anyway. Well fitting.
20 years.
Huh?
15 to 20 years.
Last 10 years.
10 years.
May not last more than 10 years. 7, 8 years. Okay.
A 35-year-old female with 8 years post-op follow-up case of humerus shaft fracture with an implant in situ. We've done implant removal, sir.
What was the reason indication?
The pain, sir. She complained of pain.
Radial nerve intact?
Yes, sir, radial nervous center.
Find out
Sir,
what
yeah,
are the
no
cause
problem,
of
sir.
the pain. Is there a late infection, implant loosening?
Yes, sir, thanks, sir. 5 times you should.
Yeah, they will face pain. We have to assess how painful
Or
it is.
sometimes corporate hospitals want to remove implants.
Even here also.
The complications are very high with
Yes.
implants.
We put the post-op X-ray.
So,
High chances of refracture. Very high chances.
How old is the patient?
it's 35. Sir.
Protect the limb. With a
Gentle mobilization.
Surname.
No need of slab.
ready-made surname braces are available.
Yes.
That will protect the from getting refracted by angular forces.
Yes.
Ideally, advise surname brace.
Yes.
Okay, next.
42 years female with closed tibial fracture of right leg, sir. Surgical classification type 1, sir.
No depression. Depression is not there.
Yes, sir.
Depression is there.
Yes, sir. Depression is there.
Very rare. Nerve fragmenting.
Here also. Look at that. 42. Okay.
This is sharp femur.
So,
Go back. So what was the reason to get an MRI, CT scan?
so you wanted to check for any intra-articular comminution?
Any breakout from here?
We didn't find any, sir, in this X-ray. So we just wanted to make sure there's no posterior comminution. Sir.
Very osteoporotic.
Yes, sir.
So there was no intra-articular extension.
No, sir, no intra-articular extension. We've done open reduction internal fixation with distal femur LCP.
Unit 1, Jerem.
Yes, sir.
Medial side, what happens?
Sir,
See this one will
there's
collapse.
no. Yes, sir.
You need to have a small plate there.
Or a fibular strut.
Support. Otherwise it could varus collapse.
Yes, sir.
Why it always goes into varus collapse?
Sir, the compressive forces act on the concave side of the.
Adductors are very, very powerful.
Yes, sir.
Adductors are very.
Yes, sir.
Moreover, there is no partial continuity.
Yes, sir.
That is the reason why they do it.
But it's nicely done, except maybe small plate here.
Yes, sir.
2 holes up, 2 holes down. Okay.
This is a 25-year-old male with 1 month-old right lateral third fracture of the clavicle.
Third or
Middle to lateral junction, sir. So you've done open reduction internal fixation with clavicular plate, and we placed on circulage wire, sir. There were 2 comminuted small pieces which couldn't be fixed with an interfragmentary screw. So we had to put. We tried to put vicryl first, sir, but it was not holding in the posterior surface. So we had to put 1 circulage wire.
How to prevent injury to the subclavian? Very close to that.
Yes, sir.
More so when you are putting a circular.
You have to avoid.
And why do you write chest X-ray? Write clavicle X-ray. Why do you want to expose everything?
I think the radiographers should be, for shoulder injuries also they are taking chest with both shoulders. Which is
Because
not
you need to go
required.
and speak to them.
They
Tell
have
them.
been
Yes, sir.
commenting on this for quite
Should go and tell them.
period.
Put a note there that this has to be done.
Yes, sir.
Okay. Next general club. Presentation.
2020. Introduction. Periprosthetic tibial fractures after total knee arthroplasty is rare but jeopardizes implant survival. The main objective of present study was to assess treatment efficacy. on the hypothesis that surgery provides good long-term results. Introduction. Periprosthetic tibial fracture after total knee arthroplasty is rare but poses a challenge due to implant survival and complexity. Risk factors include osteoporosis, advanced age, female gender, revision total knee arthroplasty, osteolysis, tibial stem design, instability or deformity. The study assesses surgical treatment efficacy over long-term follow-up. Classification, it can be classified by Felix classification based on fracture location and implant stability. Type 1, it's tibial plateau. Type 2, it's adjacent to the stem. Type 3, tibial shaft distal to the component, and type 4 is a tibial tubercle. Softcott classification, inspired by Felix, classifies fractures by location with respect to the implants, implant stability and bone stock. Whereas in type A, it's at the implant, type B, which is contact with the stem, and type 3 is distal to the stem or implant. Materials and methods, a retrospective two-center study, which is done in Nancy and Metz, France. 15 patients, out of which 9 are right knee and 6 are left, with the periprosthetic tibial fractures post TKA from January 1997 and March 2017. Mean follow-up was 12 months, range is 6 to 120 months. Significant setup is P is less than 0.05. Inclusion criteria, location less than 15 centimeters from the joint line or less than 5 centimeters from the implant component if fixation would impinge hardware. Exclusion criteria, loss of follow-up, intraoperative fracture, anterior tibial tubercle fracture, unicompartment prosthesis. Treatment strategy, non-operative management, so one fail, bedridden 91-year-old woman treated with 6 weeks of long leg casting. Internal fixation is done for 11 fractures with 9 plates, 7 are locking and 2 are standard. 2 intramedullary nails, both softcut C1. Circlage is done for 2 cases and bone grafting for 1 case due to severe bone defect. There's the fracture near implants, sir. So they have fixed with locking plate. This is a post-operative X-ray and this is a follow-up. Here is type 3, is distal to the fragment. Then they have done intramedullary nailing. Results are mean follow-up for 28 months, consolidation in 13 out of 15 cases. Yes, sir. Medial entry they have done, sir. Yes. A result. So as yes, sir. It was no, sir. They didn't give. Results are mean follow-up for 28 months, consolidation in 13 out of 15 cases, complications seen in 8 patients with infection, non-unions, nerve palsy and refracture. Surgical revisions are done in 8 cases. Functional outcome are Parker score 7, Oxford 32 and international knee score is total 150.
So out of 15, 8 complications?
8 complications.
So about 60%
Complications.
Maybe you could have done better than that.
Discussion, yes. Surgical management yields acceptable outcomes despite high complication rates. Type B fractures have had high risk of failure. Locking plates show mixed results. Intramedullary nails effective in type C because it's very distal to the component. Implant revision beneficial in type A with early mobilization. Conclusion, surgery offers favorable long-term results in periprosthetic tibial fractures, high complication rate, especially in type B fractures. Proper classification and tailored treatment strategies are essential in this. Criticism, it is a retrospective study with small sample size. and heterogeneous treatment methods and fracture types. And due to shorter follow-up duration for some cases, nonetheless comprehensive data with minimal loss to follow-up.
So they managed to publish. That's probably their presentation was good.
Thank you.
Very crisp and good presentation.
Thanks.
Well presented.
Thanks.
And what does it affect your practice?
Yes, sir. These days, as we are doing lot of TKRs, so it is future will get more likely to get more. Yes, because it is done in 2017. So at that time it was less. So we should
With this kind of
fractures, complications. Thank you, sir.
See, it should be within how many? 12 centimeters?
15 centimeters. Yeah, sir.
If it is within 15 centimeters of the component, only it's far away. It's not
Thank you. Thank you.
And that innovative nail,
That's interesting. Even I never seen one. So there is a possibility we can do it. Huh? That who is that fellow? Elastic nails.
from
Indra. He does this. Probably we invite him for our Tosakam meeting. Okay, very good. Done? Everyone is clear except you, without beards. Anjali garu.
మీరే ఆర్గనైజ్ చేయాలి బయట.
అయిపోయింది నమ్మ ఒక నెల వరకు లొల్లి లేదు ఇక చెప్పినా కదా అందుకనే 3 సార్లు చూసుకొని వచ్చిన నిన్న నీకు ఫోన్ చేస్తే ఫోన్ ఇస్తావారా నువ్వు సాయికి రిపేర్ చేసిన అంజీ అనే పేషెంట్ కోసం